Good morning, everyone. Very warm welcome to all of you to Oncology Classroom, and happy Republic Day to all of us. It's a great day, and it's a great beginning of this day by having a great lecture from one of the greatest teachers of this country. As you all know that this month we are having different topics from gynecological malignancies. Today's topic will be on endometrial cancer, and the talk will be on evidence-based management of endometrial cancer. This lecture will be delivered by Professor Umesh Mahantshetty. He does not need any introduction, not only in this country, but he is one of the most sought after radiation oncologist with his dedicated seminal work on gynecological malignancies. Sir is currently the director of Homi Bhabha Cancer Hospital and Research Center at Visakhapatnam, which is a unit of Tata Memorial Center, Mumbai. And it is a great pleasure to have sir in this forum and the opportunity to listen to him. Thank you so much, sir, to find your time among your busiest schedule and get some time for us. So I'll request you to please take over this session and start this lecture, sir. Thank you so much for being with us.
Thank you, Dodal Mandal, for this kind introduction. Can you see my screen?
Yes, sir.
So, on the occasion of 72nd Republic Day, my greetings and wishes to all of you. And it's my pleasure to deliver this talk. And I've heard a lot about this forum from my friends, colleagues, and Dr. Dodul. So I hope I do justice in delivering this talk and hope it is useful for most of you. And the task given to me is to talk to you on evidence-based management of endometrial cancers. I have no financial disclosures. To set the ball rolling of this lecture, this is a slide which shows the common cancers in women. On the left, in blue graph, is the incidence, and on the right, in yellow bars, are the mortality. And what I've highlighted in the incidence is the endometrial cancers. And you see, the striking thing is this is not very common. But nevertheless, in the Western world, it is quite on high in the list. So roughly around 10 women, every 100,000 women in the world are diagnosed with endometrial cancers. And if you see the mortality in the bottom is very low. So it is 2.4 per 100,000. So it means we have been efficiently treating endometrial cancer. And the reasons you will hear in the lecture. What about incidence in India? India, it is even lower. 2 per 100,000 women are diagnosed with endometrial cancers. However, if you see the mortality, roughly 1 per 100,000. So it means 50% mortality is still seen with endometrial cancer. Having said that, the Indian statistics are skewed because not everybody reports in an appropriate cancer incidence and mortality. My apologies, I will not go into the details of workup and diagnosis, but this slide shows basic management principles. And to just complete the scenario, very important is the imaging. Typically, a patient would present with menopausal bleeding, perimenopausal bleeding, or postmenopausal bleeding and go to a gynecologist. A general gynecologist would typically do an ultrasound abdomen, transvaginal ultrasound to identify that the endometrium is thick or there is a polyp in the endometrium cavity, which then further goes for a biopsy or endometrial curettage. And through this, the diagnosis of endometrial cancer is usually done. And for histology type, for practical purposes of management, it is divided into type 1 histology and type 2 histology. The type 1 is the classical endometrioid adenoceae of the endometrium. The type 2 histologies are other histologies which include clear cell, serous, carcinosarcomas, sarcomas, and undifferentiated tumors as well. But what is important if you have read the basic chapter of endometrial cancers, is summarized in the following. Since bleeding is the presenting symptom, usually women present very early, and during the early, because by virtue of early presentation, the diagnosis is also done earlier, and usually they are picked up in early stage. So most of the patients would have early stage at diagnosis. And the next most important parameter is that surgery is the main treatment. Once the surgery is done, the next important step is detailed histopathology report. And detailed histopathology report is mandatory. The reason is that for endometrial cancers, the staging proposed is a surgico-pathological staging. And if you do not have appropriate surgery and a detailed histopathology report, you cannot stage the patient who has been diagnosed with endometrial cancer. What I've highlighted in red is according to be the most important prognostic factor for the outcome of endometrial cancers. The surgeon who is operating and the pathologist who is reporting the specimen. These two are the most important prognostic factors for the outcome of endometrial cancers. And in surgery, when I said it is standard to TH plus BSO, lymphadenectomy role is not well defined. And I will take you through what has to be done depending on the histopathology of the primary tumor. The last important principle is adjuvant therapy is tailored according to surgical pathological staging. Suffice to say that radiation therapy in an adjuvant setting is an established treatment modality. What is being researched is chemotherapy or combination of concomitant chemoradiation, and these are all ongoing research works in a large phase 3 randomized trials. The staging is classically done by FIGO, and it was revised in 2009. And what I've highlighted on the left is the 2009 staging. To cut it short, stage 1 endometrial cancer is tumor which is confined to the uterus. Earlier it was divided into 1A, B, C. Now it is 1A and B based on myometrial invasion. Less than half up to less than half myometrial invasion is 1A. More than half myometrial or equal to 50% invasion of myometrium is 1B. Stage 2, which was classified into 2A and B earlier, now it is single stage. Stage 2 is a cancer which has invaded cervical stroma but is not extending beyond the uterus. Stage 3 is locoregional spread of the tumor. It is subdivided into stage 3A, B, and C. 3A, when the tumor is extending into the serosa or adnexa, that is ovary or fallopian tubes. Stage 3B is by virtue of involvement of vagina with or without parametrial invasion. Stage 3C is metastasis to the regional lymph nodes. So if the regional lymph nodes in the form of pelvic nodes are involved, then it is classified as stage 3-1. And if paraotic nodes are involved with or without pelvic nodes, it is stage 3C2. And stage 4 is invasion of bladder or bowel mucosa and or all distant metastasis. Coming to the today's talk, evidence-based management. This is a slide which shows that there have been many guidelines, recommendations for diagnosis and treatment of endometrial cancers. For example, there have been French guidelines, there have been ESMO guidelines, and there have been Italian guidelines. But what I'm going to present today is the latest consensus guidelines, which comes from the ESMO, ESGO, and ESTRO. ESMO is Medical Oncology European Community, ESGO is Gynae Oncology Committee from Europe, and ESTRO is Radiation Oncology Community. And believe me, the names of the authors you see are all big names in publications in terms of management of endometrial cancer. And if you want to go into the details, this was published in 2015, updated in 2016 and 17. So coming to the principles of treatment, the surgery is the mainstay of treatment, as I mentioned earlier. And the standard surgery is total hysterectomy with bilateral salpingo-oophorectomy without vaginal cuff. and the strength of recommendation is B. In recent past, as you know, there have been advances in surgical skills. Minimal excess surgery is the buzzword in the community. And for endometrial cancer, it is quite safe to implement minimal invasive surgery and is recommended for low risk and intermediate risk and can be considered for high risk endometrial cancers. I'll come in a minute what these risks mean. As I said in my earlier slide, lymphadenectomy is quite controversial issue. The issue why it is controversial is shown here. It is very difficult to find out which patients would benefit from lymphadenectomy. If we have to do a lymphadenectomy, whether we should do pelvic or para-aortic or both. If we do a lymph node dissection in endometrial cancers, what is the prognostic impact? If the nodes are positive, what are the treatment modifications? And last but not the least, if we do a lymphadenectomy, is there a therapeutic benefit if patients undergo lymph node dissection? These are the recommendations from ESTRO based on the risk stratification. So for surgery, so the patients are classified into low, intermediate, and high risk based on the grade of tumor, invasion of myometrium. And based on this, they are classified into low, intermediate, and high risk. As of today, for low risk endometrial cancers who have undergone surgery for primary tumor in the form of TH and BSO, lymph node dissection is not recommended. And the level of evidence is level 1, strength of recommendation is A. For intermediate risk, which comprises of deep myometrial invasion or grade 3 with superficial myometrial invasion, it is still equivocal. It is not very well defined whether it should be done in all patients. However, in recent past, there have been advances where a couple of series have shown the safety profile with sentinel lymph node sampling or dissection. And currently, it is extensively researched both in Europe as well as US. What is definitely recommended is for high risk, that is stage 1, grade 3 with deep myometrial invasion or stage 2, stage 3, definitely lymph node dissection is recommended. If lymph node dissection is recommended, what is the standard surgery? Standard surgery recommended is systematic removal of pelvic as well as para-aortic nodes up to the level of renal veins should be done in most of the patients where it is indicated. For example, high risk stage 1 and stage 2 and stage 3. For stage 2, there is always a question. What is a primary surgery to be done? Primary surgery is radical surgery like cervical cancer. It is a modified radical hysterectomy type B or sometimes type A. This is Moro-Coelho classification, and you can go into the details if you wish to. And for stage 2, as I mentioned, lymphadenectomy is recommended for stage 2 endometrial cancer. For stage 3, stage 4, the primary surgery aim is to do complete macroscopic cytoreduction so that we land up with a comprehensive staging. And based on comprehensive staging, we could tailor the treatment in advanced endometrial cancers. Slide on non-endometrioid cancers. The surgery more or less is similar, except that we add staging omentectomy for a particular histology. For example, serous carcinoma patients should always undergo staging omentectomy like ovarian cancers. And for other histologies like clear cell or undifferentiated endometrial carcinoma and carcinosarcoma, the omentectomy need not be done. However, in type 2 histology, most of the patients should undergo lymph node dissection, complete lymph node dissection as mentioned earlier. Coming to once the adequate surgery is done for these patients and once histopathology report, detailed histopathology report is available, then the next question is adjuvant therapy. And my recommendation is that irrespective of what treatment modality you would offer, please ensure that these patients are discussed in a multidisciplinary meeting with a surgical oncologist, the gynae oncologist who has operated on the patient, the gynae pathologist, the radiation oncologist, as well as medical oncologist minimum. And the adjuvant therapy is based on this new risk group classification. As I mentioned earlier, there have been various risk groups defined by European groups. Even in Europe, there was a risk group defined by French. There was a risk group defined by the Netherlands group. And in US, the risk group was also defined by GOG. However, what I've shown in this slide is the most commonly utilized risk classification now, and that is coming from the ESDO, ESMO, and ESTRO consensus. And the risk classification is into low risk, intermediate risk, high intermediate risk, which is shown in this table. And patients are deemed low risk if the histopathology report says that it is stage 1 endometrioid histology, grade 1 and grade 2, less than up to 50% of myometrial invasion. What is important is the LVSI should have been reported negative. So 1A, grade 1, grade 2, LVSI negative would be low risk. On similar lines, if it is 1B, grade 1, grade 2, LVSI negative, then it is intermediate risk. The high intermediate risk group is the new risk group which has been introduced in recent past, and this consists of two groups. If you see the low risk group, 1A, if it is 1A grade 3, irrespective of LVSI, is classified as high intermediate risk. And the second group is stage 1, grade 1 and grade 2, LVSI positive. So these are the two groups of patients who would be classified as high intermediate risk. And the other group is high risk, where patients have stage 1B grade 3 or stage 2 stage 3 with no residual disease after surgery. All patients, irrespective of the stage, if the histology is type 2, that is serous or clear cell or undifferentiated or carcinosarcoma, they are always labeled as high risk, provided there is no macroscopic disease. The advanced stage is defined as if patient has gross residual disease after surgery and metastatic for stage 4B. So based on these risk groups, the adjuvant therapy has been defined efficiently now. For example, low risk, stage 1, grade 1, A, 1 and 2, LVSI negative. There is a level 1 evidence suggesting that this patient does not require any adjuvant therapy. Mind you, even for this group, there is no lymph node dissection recommended. So if patient has undergone TH-BSO alone, no lymph node dissection, and if the stage is 1A, grade 1, grade 2, or LVSI negative, this patient does not qualify for adjuvant therapy. And the reason is the outcome is as good as 90%. There was a randomized trial from Norway which said that there is no benefit of giving adjuvant radiotherapy because the recurrence relapse rates are very, very low in this low risk group. For the intermediate risk group, which consists of stage 1B, grade 1, grade 2, LVSI negative, there are two recommendations. Either you offer adjuvant brachytherapy to decrease the vaginal recurrence, or you could observe these patients, provided these patients have an age or have younger age group or in the younger age group of less than 60 years. And the reason why these two are recommended is shown in this busy table with various randomized trials. And on the left, you can see the randomized trials which were published and which most of you should know is the Norwegian trial, the POTEC one, the GOG 99, and the Aztec trial. I don't want to go into the details of the whole table, but for low risk and intermediate risk, what is important is obtaining adequate local regional recurrence is the aim of treatment, because irrespective of whatever treatment you give, you see these randomized trials, there is no difference in survival. So if you go into the more details of this table, what it shows is that if you offer some form of radiotherapy, the local regional recurrence is definitely significantly lower. If you offer brachytherapy alone, then the local recurrences are reduced. If you offer external beam, maybe local regional recurrences are further reduced. So the other trials, the Norwegian and Aztec trials, showed that whether you give external beam or brachy, the local control is similar, more or less, and there is no difference in survivals. Hence, in intermediate risk group, you have these two options of offering only adjuvant brachytherapy. Many a times, adjuvant external beam is also given, but I will show you why we should not give external beam and offer only adjuvant brachytherapy. Mind you, again in this group, you need not mandate a lymph node dissection for these patients. So, but the key is the pathologist should report all the histopathological report in detail, including the grade, the depth of invasion, the classical report of lymphovascular space invasion. And if they are negative, then these patients can be offered these two treatment options. This is a new risk group, that is high intermediate risk. This has two types of two groups of patients, 1A grade 3, and the other group is stage 1, grade 1, grade 2 LVSI positive. Now comes the controversial issue of lymph node dissection to be done or not done. If you have already done a lymph node dissection, on the left is the treatment recommended if the lymph nodes are negative. So if the lymph nodes are negative and patient has these stages, you could conveniently offer adjuvant brachytherapy alone to decrease the vaginal recurrence. And the other option could be in a patient who is relatively young, has a grade 1 tumor, stage 1, but only LVSI is positive. Still, this patient would would be given no adjuvant therapy option as well. However, if you see the strength of recommendation is C, because the level of evidence is low. So most of the patients in our country would err on adjuvant treatment in this group. If surgical staging is not performed and LVSI is positive, there is no option then to give adjuvant external beam radiation to these patients. If the gynecologist is confident that he will take this patient again back to the OT for surgical nodal staging, then it is fine. But if patient, many a times, 9 out of 10 times, gynecologist would say post-operative complications become very high. So in such situations, if LVSI is positive, adjuvant external beam radiation is offered. And for 1A grade 3, adjuvant brachytherapy alone may also be recommended to decrease vaginal recurrences. And for high intermediate risk, what I've concluded at the bottom is systemic therapy is of uncertain benefit. And these are being researched in a clinical trial setting and should not be offered to patients who come in the group of high intermediate risk. And this recommendations come from this classical POTEC 1 high intermediate risk group patients, where these patients who had at least two or more of the risk factors, including grade 3 outer myometrium invasion or age more than or equal to 60 years. POTEC 1 study showed that reduction of recurrence by roughly around 25 to 30%. And by doing this, they could reduce the utility of adjuvant treatment for these patients. But if you see carefully, the graph on the left, if we do not offer adjuvant radiation, what is seen is higher locoregional recurrences. And out of these locoregional recurrences, 75% had vaginal recurrences. So suffice to say that the patterns of relapse suggest that vaginal recurrences are more common in patients with high intermediate risk without any difference in outcome in failure-free survival. This is also a table which shows on the left POTEC high intermediate risk group, on the right the GOG 99 study, where these two groups had different criteria of defining the high intermediate risk groups, but more or less they are synced with what the literature says now for the outcome in terms of adjuvant therapy and local recurrence as well as survival. And this is GOG 99 recurrence patterns for high intermediate risk. You see the benefit of giving RT is as much as 50% reduction in locoregional recurrence. However, what is important is when you offer adjuvant external beam radiotherapy, which was done in POTEC 1 as well as GOG 99, what they showed was the toxicity after surgery and external beam is very high. For example, in GOG 99, the toxicity, grade 3, grade 4 toxicity was as high as 13%. And please remember, these patients had undergone extensive surgery in the form of lymph node dissection, both parotid and pelvic. And or above external beam was given with box field technique. So you have to be very careful. So there was another randomized trial, POTEC 2, for similar high intermediate risk groups. where they randomized to pelvic radiation versus vaginal brachytherapy. And what the POTEC group showed for the first time with a median follow-up of 10.5 years is that there is no difference in outcome in terms of vaginal recurrence, and no difference in overall survival. However, what they showed was that a vaginal brachytherapy arm had significant reduction in vaginal relapses, whereas there was a slight increase in pelvic relapses other than vagina in patients who received vaginal recurrence alone. However, there was no difference in distant metastasis. But what they showed was that in patients who received external beam radiation, patients had worse quality of life in terms of bowel symptoms, in terms of daily activities, as well as the sexual activity was also significantly lower in patients who received external beam radiation. Hence, for high intermediate risk group, we usually tend to offer vaginal brachytherapy alone after surgery. What is important for you is to go back to pathologist if they have not reported LVSI, to report the LVSI and further motivate them to classify the LVSI which is seen on the histopathology report into focal and substantial or extensive LVSI. And the reason we say that is the research which has come from POTEC group is shown on the left side from POTEC 1 and POTEC 2 studies, where they first time showed that if patients have substantial LVSI on histopathology report, the relapse rates are higher. And these relapse rates in the form of pelvic node recurrences are higher as compared to no LVSI or mild LVSI. And even in patients who have substantial LVSI, if you see on the right side, which amounted for 5% of the POTEC studies, the treatment offered also is vital. If patients have extensive or substantial LVSI, these patients should be offered external beam more than vaginal brachytherapy, because if you see the outcome here, patients who have been treated with vaginal brachytherapy or not offered treatment have higher relapses rate in the pelvis as compared to patients who have undergone external beam radiation alone. Coming to the fourth group, that is high risk group, that is 1B grade 3, and regardless of LVSI. Again, based here, as I mentioned earlier, lymph node dissection is recommended. And if lymph node dissection is not done, and if surgeon says he is not, we will be able to offer this lymph node dissection, then the recommendations is to give adjuvant external beam with limited fields to decrease the locoregional recurrence, and the level of evidence is 1. Alternatively, adjuvant brachytherapy may be considered to decrease the vaginal recurrence. However, the level of evidence is not strong. It is 3. And last but not the least, adjuvant systemic therapy, which is discussed in extensively these days, is investigational in high-risk group. However, if surgical nodal staging is not performed, then patients will definitely require external beam radiation to control the pelvic disease as well as relapse-free survival. There are studies, couple of retrospective as well as some prospective studies, which are in favor of giving adjuvant chemo in such group of patients. And however, what is debated is sequential or concomitant or adjuvant chemotherapy. How should it be sequenced with adjuvant pelvic radiation is the question which is being discussed in various randomized trials, and show you a couple of them. The next group is the high-risk stage 2. In high-risk stage 2, it is very important that type A or type B hysterectomy is done. And if patients have undergone pelvic lymph node dissection extensively, then the recommendations are many, because this is again a controversial issue where there is no much data on large number of patients. And remember, stage 2 accounts for less than 5 to 10% of the patients who have undergone surgery. So if patient has grade 1, grade 2 LVSI negative, vaginal brachytherapy alone would suffice, provided the nodes are negative. Whereas if it is grade 3 or LVSI unequivocally positive, then limited pelvic field radiation could be offered to these patients. And in these group of patients where it is stage 2, where cervix is involved, boost may be considered to reduce the relapses in the vagina. And last but not the least, chemotherapy in stage 2 adequately undergoing surgery is controversial and investigation and still part of the research protocols which are ongoing. If surgical lymph node staging is not performed, it is very simple, very easy. External beam radiation like high risk group should be offered. Brachytherapy boost should be considered in these patients. And for adjuvant chemo, as I said earlier, sequential adjuvant chemo has some role in these patients to reduce the progression-free survival. Coming to stage 3 with no residual disease, this is more or less similar to stage 2. However, here again the recommendation is to add chemotherapy as early as possible so that the systemic relapse or progression-free relapse can be reduced. As I said, cause-specific survival and progression-free survival can be improved with chemotherapy. But what is controversial is the sequencing of chemotherapy and external beam in stage 2 and stage 3, which have been discussed in various chemotherapy trials, and I will show you a couple of them. A word on type 2 histology. Depending on the type of histology, for serous and clear cell after comprehensive staging, which means lymph node dissection, and for serous omentectomy, chemotherapy is also recommended, and clinical trials are ongoing to establish this role, because type 2 histology again are very rare and account for 15 to 20% of the histologies. If patient has stage 1 LVSI negative, we usually give brachytherapy alone, and may or may not be considered for adjuvant chemotherapy, because there is no clear-cut evidence in stage 1A type 2 histology whether chemotherapy would be beneficial. For stage 1B or more, then external beam for sure should be given to these patients to reduce locoregional recurrence, and chemotherapy for sure should be offered to these patients, because the relapses, systemic relapses also are higher once the stage becomes more than 1B in 2 and 3. For carcinoma, sarcoma, and undifferentiated tumors, usually we offer chemotherapy, and external beam radiotherapy role is not very well established. But nevertheless, with the aggressive behavior of carcinosarcoma, invariably for stage 1, stage 2, we tend to give pelvic radiation to reduce the locoregional recurrence. So for the high risk and stage 2 and stage 3, there were 2 trials which have been discussed extensively in most of the meetings these days. The first trial is the POTEC-3, which was 700 odd patients randomized to the standard of arm of pelvic radiotherapy, consisting of 46 grain, 25 fractions over 5 weeks, versus the study arm of pelvic radiation with concomitant chemo of cisplatin 50 milligram per meter square into 2 cycles, followed by adjuvant carboplatin and paclitaxel. And the importance of this trial is that there was a central pathology review of all the patients so that the staging was appropriate. And these patients then were first time reported with overall survival and failure-free survival. And you see, this was a trial which had 2 co-primary endpoints, overall survival and failure-free survival. And these are the graphs which show that there was a 5% improvement in relapse-free, in failure-free survival, in overall survival, and 7% improvement in failure-free survival, both statistically significant. But what is important in POTEC-3 was that the magnitude of benefit was highest in stage 3 microscopic stage 3 disease. The survival, the benefit was up to 10% by overall survival and 12% by failure-free survival. And the outcome was even better in type 2 histologies, which amounted for roughly 30% of the patients. And the benefit, if you see in this lower part of the slide, the benefit was as high as 18% in overall survival and 12% in failure-free survival. So suffice to say that chemoradiation should be the treatment of choice for stage 3 microscopic disease who have undergone adequate staging, or if they have type 2 histology and stage 2 and stage 3. The other trial which is discussed is GOG 258. The difference between the POTEC-3 and GOG 258 is that in GOG 258, the standard arm was considered as chemoradiation, which is there in the study arm was again concomitant chemoradiation, which like POTEC-3, but the standard arm was chemo alone, because there were a couple of GOG studies earlier where they showed that adjuvant chemotherapy should be given to these stage 3, stage 4 patients. And the second difference between the POTEC 3 and GOG 258 is that in this trial, there were more advanced disease and more type 2 histologies than what was seen in POTEC 3. And what they showed was with the primary endpoint of recurrence-free survival, there was no difference in the two arms, chemoradiotherapy or chemotherapy alone. And you see both the graphs, survival curves hugging each other on the left side. However, in patients who received only adjuvant chemotherapy alone, vaginal recurrences and pelvic recurrences pelvic or parotic recurrences were higher as compared to patients who received chemoradiotherapy. And for patient, and the last graph where it shows that patients who received chemoradiotherapy tend to have more distance recurrences than patients who are receiving chemotherapy alone. But if you compare stage 3C, on the left side is the POTEC study, on the right side is the GOG 258. And what I want to show here is, on the left side is failure-free survival. 5-year survival reported with concomitant chemoradiation protocol was 71%, whereas in GOG 258, 5-year survival was 58 to 59%. And the reason I have put this comparison is, although both were stage 3 microscopic disease, you see there is a 10%, at least 10% difference in the outcome. So it means there is definitely a different spectrum of stage 3 disease in POTEC 3 and in GOG 258. I'm not sure what is the intricate details, but this is the reality as of today. If you go into the details of these two randomized trials, on the left side are the various endpoints I have put in blue. In the second column, in the second and third column is the POTEC arm, and fourth and fifth column are the GOG 258. In POTEC 3, as you know, the randomization was between adjuvant external beam versus chemoradiation, whereas in GOG, it was chemoradiation versus CT. And CT-RT arm of POTEC 3 and CT-RT arm of GOG 258 were similar in terms of offering the adjuvant treatment, that is adjuvant radiation with concomitant chemo followed by adjuvant chemotherapy 4 cycles. And what I have shown here is compliance. You see there is for concomitant chemoradiation, the compliance is more or less 90%, 90% above for radiation as well as chemo. But the compliance reduces for adjuvant chemo, that is 4 cycles of chemo, roughly around 75%. But if you see chemotherapy alone, overall, the compliance rate is only 85%. Suffice to say that the compliance reduces by 10% if you're giving chemotherapy alone for 6 cycles. Whereas if you're giving concomitant chemoradiation, the compliance to concomitant chemoradiation is 90%, and for adjuvant, it is 75%. And what I've highlighted in next 2 rows is the loco-regional recurrences. And if you see whether you've given adjuvant radiation or chemoradiation, the vaginal recurrences or pelvic recurrences are more or less similar. Whereas if patient doesn't receive pelvic radiation, that is the last arm, that is CT alone, the pelvic relapses are higher. The other row you see the systemic relapses. There is always an hypothesis. If you give adjuvant radiation alone, the systemic relapses are higher. But you see in the POTEC, the systemic relapses were 29%. Patients who received concomitant chemoradiation, whether it was POTEC 3 or GOG 258, the systemic relapses are roughly around 25%. And last column, interestingly, even if patient receives 6 cycles of chemo, the systemic relapses are 21%. So there's a moderate gain of systemic relapses if you give chemo alone of, let's say, 5% as compared to concomitant chemoradiation. But if you give concomitant chemoradiation, the pelvic relapses, the loco-renal relapses are significantly lower as compared to CT alone. Having said that, these are not head-to-head comparison. This is only a analysis, snapshot analysis, where I have gone into the depths of these trials. What is important in the last column is, again, the toxicities, grade 3, grade 4 toxicities, roughly around 5% for concomitant chemoradiation, and for chemo alone also is 5%. So as I said, there is a modest reduction in systemic relapses if you give chemo alone as compared to radiation. Whereas if you give concomitant chemoradiation, apart from achieving adequate systemic control, you will also land up with adequate locoregional control in these advanced stage disease. Few words on what radiation therapy protocol. As you know, in POTEC studies as well as GOG studies, box field radiation was delivered to these patients. In fact, in POTEC 1, 30% of them received parallel opposed APPA fields. And by today's standards, by no means, none of the patients should receive APPA fields for endometrial cancers. And the reason I say this is that all these patients who require adjuvant external beam radiation should undergo pelvic IMRT, not conventional radiation, because this is a trial, time-C trial, RTOG trial, which shows that in post-op cervix and endometrial cancers, the outcomes are better in terms of reduction in toxicity. And this is an old publication, but now you have new outcomes which have been discussed in Astro recently. For brachytherapy, it is very important that the length of vagina you radiate is as short as 3 to 4 centimeters. The reason why we say this is when you're offering brachytherapy, you should only treat 3 to 4 centimeters of top of vagina, because if you see POTEC 1, POTEC 2, MRC Aztec and GOG, the length of the vagina treated by brachytherapy was roughly around 3 to 4 centimeters. And if you see the vaginal relapses, it is less than 1% or 1.5%. So there's always a question. A lot of seniors would say, no, there is a high chance of relapse in the lower third of vagina. Lower third of vagina is never treated with brachytherapy, because if patient has lower third vaginal recurrence, it is called vaginal metastasis and not recurrence. And the reason why we don't see vaginal metastasis that often after we give vaginal brachytherapy for top 3 centimeters is that when we treat the top 3 centimeters of vagina with brachytherapy, the vaginal wall gets fibrosed, gets radiated, because of which the drop mets, apparently the hypothesis is that the cells would not migrate down through the submucosa into the lower third vagina. And the reason why they get stuck in lower third vagina is because of the embryological anatomy, where there is a ecto and endodermal junction. That is where they get trapped if vaginal radiation is not given. So the hypothesis is if you radiate upper 3 centimeters of vagina, vaginal metastasis automatically reduce. So this is a summary slide which says what treatment should be offered. For low risk, surgery alone. For intermediate risk and high intermediate risk, vaginal brachytherapy, depending on pelvic lymph node dissection done, not done for especially high intermediate risk. And patients who have high intermediate risk with LVSI positive and lymph node dissection not done, these patients could be offered pelvic IMRT. Definitely for high risk, please remember pelvic radiotherapy is mandatory. What is controversial is combining chemotherapy, either with radiation or adjuvant chemotherapy, is still debated, and still a lot of discussions happen how to sequence chemo and radiation. But my take on this is concomitant chemo like POTEC 3 protocol is quite easy and doable in a clinical setting. No doubt there might be 75% compliance to adjuvant chemo after 4 cycles, but still these patients would land up with a modest outcome compared to chemotherapy alone or radiation alone. Few slides. What is emerging in last few years is what I've shown here, the molecular signatures of endometrial cancer by the TCGA. And what they have come up with is the classical 4 types of the histology, molecular histologies. One is poly, second one is MSI, the third group is low copy number, and the fourth group is high copy number, that is P53 mutated endometrial cancers. And why these are important? These markers, more or less, these classification more or less have a prognostic significance. And if you see in the graphs shown here, locoregional recurrence, distant metastasis, and overall survival, in P53 mutated tumors, you see the outcome is poor as compared to others. And on similar lines, even for type 2 histology, the similar classification also holds true for the outcome. Whether this classification, molecular classification into, let's say, poly, then MSI, and low copy number, and P53 mutated, does it help to tailor our treatment? Yes, there are some studies now from the POTEC 3 group where they are showing that patients who have been treated with concomitant chemoradiation tend to do better than patients who have offered single adjuvant radiation alone in patients who have P53 positive stage 3 endometrial cancers. And there is a lot of work in progress. I don't want to go into the details, but there is a classification which has been proposed, molecular classification, which may be implemented in routine clinical practice very soon. In fact, it might be already in press now. The clinical implementation of these molecular markers, it will definitely help in stratifying the risk groups for better, tailor the diagnostic as well as surgical management and adjuvant treatment based on these markers. For example, there's a PORTEC 4A, which is ongoing study. Now I think recruitment is more or less closed. Then the other studies which have been defined based on the high risk group is they are evaluating the role of PARP inhibitors in patients who have P53 mutation. There are also studies with checkpoint inhibitors as well as HER2 new trastuzumab. Many studies have been done to classify further and to identify the importance of these molecular classification. So this is an example of PORTEC 4A, where they are classifying these patients based on molecular markers into favorable, intermediate, and unfavorable. And patients who have favorable are being observed or would be offered randomized to vaginal brachytherapy. And intermediate risk group are being offered vaginal brachytherapy, and unfavorable group are offering external beam radiotherapy. However, what is important to realize is still there is a lot of research to be done in terms of trying to find out which endometrial cancer patients who require adjuvant therapy, who would benefit from adjuvant therapy. Suffice to say that we need some markers for research to identify which are radio-resistant tumors and which are not. And based on this, we could tailor the adjuvant radiation further for this group of patients. I thank you for your patient listening. And this is just a photograph of 2 tigers which we spotted in Ranthambore with my family recently. Thank you.
Thank you so much, sir.
I hope I am on time.
Sir, on a holiday, almost 200 people listening to your talk, that says it all.
Yeah, thank you.
Sir, how much time do you have? There are a lot of questions in the chat box.
Yeah, I can have 10 minutes, 15 minutes, no problem, because okay. I have even 1 hour for this talk. So
the first question is, rectal serosal deposit belongs to which stage?
Rectal serosal deposits, I would take it as stage 4 and metastatic, because it is by virtue of seeding, of course, but this is a different class of patients where you would go for extensive surgery and hope for the best. But there is nothing given as such in FIGO.
The next question is, are type 2 endometrial cancers stage similar to type 1 or like ovarian tumors?
Serous is more or less, most of them follow the same staging except for the sarcomas. But the other histologies, we more or less stage by FIGO 2009. And why we have kept the same staging is that the adjuvant therapy, tailoring the adjuvant therapy also helps us. For example, in stage 1, serous carcinoma, there is no role of adjuvant external beam or adjuvant chemotherapy. Whereas in others, we would try to give chemotherapy as well as radiation. And the radiation typically is being given with vaginal brachytherapy so that patients get adequate local treatment at the same time systemic therapy also.
The next question is, depth of invasion and all the pathological details will be available only after the surgery done. So how is lymphadenectomy decided on table?
It's a very good question. So after the tissue diagnosis of endometrial cancer, there are 2-3 approaches people do. First approach, in a multidisciplinary meeting, we decide what investigations have to be done before this patient is taken up for surgery. So surgery, in fact, is one of the investigation for endometrial cancers. So in the clinic, what we do is, if it is grade 1 on histology or grade 2 on surgeon says it was only a polyp on the ultrasound, then we would ask for an MRI to find out the depth of invasion. And if it is grade 1, grade 2, then this patient, when patient is offered surgery during THBSO, only lymph nodes are assessed by the surgeon. They would not go for lymph node dissection unless you have a frozen section. And on frozen section, there is an upstage of the grade from grade 2 to grade 3, or the depth of invasion is seen on frozen section. So if depth is more than 50%, if it is grade 3, then these patients would go for lymph node dissection upfront. But I know in India, a lot of places, there are no frozen section availability. In such situations, my second approach is what I like. That is, do an MRI, assess the depth of invasion with various sequences. For that, you will have to sit with radiologist. Sometimes even transrectal and transvaginal ultrasound will also help and is handy to find out what is the depth of invasion. Second, if the grade of tumor has been grade 1, grade 2, these are the patients who would go for THBSO alone if the MRI is not showing deep myometrial invasion. Whereas if the patient has deep myometrial invasion and grade 1, grade 2, or grade 2, grade 3, there is a gray zone by pathologist, then we would go on over treatment in terms of doing a lymph node dissection. And the third group is general gynecologist, where they would not bother anything about this grade or depth of invasion. They would directly go for a THBSO. And I think that is the best approach which many people take in this country, because after doing that and histopathology report, they are referred to a higher center where we again discuss in gynae oncology meeting, where gynae oncologist would say, okay, I can go in and remove the lymph nodes, or I don't like to go in based on the histopathology review. So these are the three options.
Thank you, sir. The next question is a few words on the role of adjuvant chemo and radiation in patients with uterine leiomyosarcoma.
Okay. Oh, sorry, I didn't cover the leiomyosarcomas, but
No,
again,
we had a dedicated class on uterine sarcomas as well.
Okay.
But Dr. Ajit Gandhi requested you to have a few words on this.
Sure. So LMS uterus, again, staging is different. And what is important is, if you have a diagnosis of LMS, lymph node dissection is mandatory. And based on the lymph node dissection histopathology, then you could tailor your adjuvant treatment. In LMS, there is no proven role of adjuvant pelvic radiation. But what we tend to do is we tend to give brachytherapy to reduce the local recurrences, because even in LMS, the surgery, adequacy of surgery is questioned. In patients who have node positive LMS, adjuvant chemotherapy has been attempted, but suffice to say that there's a meta-analysis which shows that there is no role of adjuvant chemotherapy in uterine sarcomas. Having said that, now people are moving towards more targeted therapy. Even in LMS, they are trying to do newer markers to find out whether they can chip in the targeted therapies. So like, for example, Herceptin is also being tried if the patients have HER2 positive in LMS. So such things are being explored, but in research area.
Thank you, sir. The next question is, do we comment on parametrium in follow-up examinations in patient post-radical hysterectomy?
No. Yes, because even in radical hysterectomy, if you go back to your surgeon and find out how radical they have done parectomy, it is always the medial 2/3 of the parametrium which is dissected. So this is by a trained gynae oncologist, whereas patients, gynecologists who claim that they are doing radical hysterectomies, invariably they usually dissect less than half of the parametrium to be on safer side, to avoid ureteric injuries and other vessel injuries. So my take on this is, every patient you should try and assess the parametrium, try to identify if there is any parametrial tissue.
The next question is, what is limited field EBRT, and should we treat longer length of vagina if serous or clear cell histology?
Okay. So very good question. Limited pelvic radiation, what was mentioned in my slide. And the reason why we said pelvic limited was, these are the patients who are LVSI positive and adequately undergone lymph node dissection. And after lymph node dissection, all lymph nodes are negative and LVSI positive. So in such situations, we try to offer limited pelvic radiation. And in limited pelvic radiation, if you see classical for cervix, we always go L4, L5 or L3, L4 based on the common iliac bifurcation. in limited pelvic fields, we would come down at the level of common iliac, where common iliac would divide into external and interiliac. So the upper border of the radiation field would be stopped at the level where common iliac bifurcates into external and internal iliac. And the second part of the question was length of vagina to be radiated. Yes, there are a lot of centers who try to radiate longer length of vagina in serous and clear cell. Having said that, there is no clear-cut evidence in favor of increasing the length, because in these histologies, invariably patients have systemic relapses. Even if they have vaginal relapses, it is always a combination of vaginal as well as systemic relapses. So I wouldn't go for a longer length of treatment in vagina for these histologies.
Thank you, sir. Dr. Gauri Gandhi said, thank you, Dr. Umesh, excellent presentation. The next question is, how would you treat a medically inoperable endometrial cancer?
Sorry for that. Again, I didn't cover that in my talk, but I think it is coming up in a big way now, because obesity, then life expectancy is increasing across the world. So there are a lot of patients who have obesity, comorbidities in the form of hypertension, cardiac issues, uncontrolled diabetes, and weighing more than 120 kgs. In such patients, many times gynae-oncologists would not offer surgery as a treatment. So in such situations, there are a couple of retrospective series published from US as well as now Europe, where they have treated with a combination, either with brachytherapy alone, if the patient has less than half of the myometrial invasion, or patients who have more than half myometrial invasion, external beam and brachytherapy. And with this combination, they have shown a decent outcome of almost up to 90% at 3 years, which is more or less similar to what these patients would land up. But what is important is to realize is, in these patients, we should not look for an endpoint like overall survival, because overall survival is truncated by the fact that these patients die of other comorbidities than endometrial cancers. For more advanced disease, which is inoperable, these patients always receive a couple of cycles of chemotherapy, paclitaxel, if they are fit. If not fit, then they always receive a combination of external and brachy. What is important is, somebody would ask, how would you do brachytherapy then without anesthesia? Yes, you can do brachytherapy with spinal anesthesia or locoregional anesthesia, because here your intention is to treat only the endometrial cavity with a single tandem and a cylinder in the vagina. So it is not a very complicated brachytherapy procedure for these endometrial cancers.
Dr. Sarika Gupta and Dr. Padma Raju, thank you for your excellent talk. Next question is, traditionally, brachy boost is given in all patients post-EBRT, irrespective of risk stratification. Should we change, or is it right?
My suggestion, stop doing that from today, because there is no evidence that combining external beam and brachytherapy improves the locoregional control or the vaginal recurrences over and above external beam alone or brachytherapy alone. The only case scenario where you should give brachytherapy boost is in patients who have stage 2 LVSI positive, and if you feel that these patients would definitely benefit from vaginal brachytherapy boost to reduce the recurrences further. Having said that, even this recommendation is level 3 evidence and grade C recommendations. So it means the number of patients to really qualify that there is an advantage of giving brachytherapy boost is not clearly defined in the literature. This comes from only a small San Diego series where they have shown that if you don't offer vaginal brachytherapy in stage 2, the vaginal recurrences tend to be slightly higher. But again, this is retrospective analysis, not very clear.
The next question is, if parametrium is involved preoperatively, should we go for surgery?
If parametrium is involved by virtue of, let's say, either a transrectal ultrasound or MRI, then decision is done in the multidisciplinary team again. If gynae-oncologists feel that he is confident to do parametrectomy without any problem, then patient should go upfront surgery. If not, then this is defined as advanced endometrial cancers, And for advanced endometrial cancers, protocol as of today is that give 2 to 3 cycles or 4 cycles of chemo, assess for surgery, and then take the treatment further depending on the response.
Thank you, sir. Dr. Manish Sharma, Dr. Navneet Agarwal, thank you for your excellent talk. The next question is, can we consider sequential radiation followed by chemo in stage 3 and 4 to reduce toxicity?
Yes, this is a debated question a lot in many forums. I had a meeting on Saturday as well last week. A lot of them have, especially medical oncologists, have this apprehension that concomitant chemo like POTEC 3, cisplatin 50 milligram per meter square during radiation, and adjuvant chemotherapy, cisplatin and paclitaxel, may not be well tolerated by Indian patients. But having said that, this is an area of research where we could come up with a answer that validity of implementation of POTEC 3 protocol in Indian setting would be a research protocol which should be done in this country. Having said that, even our medical oncologists are not very comfortable. So what we did was, before the final results of POTEC 3 were out, if you recollect, the first interim results were negative and they showed only stage 3 advantage. That time we had a consensus that these patients would go for 4 cycles of paclitaxel followed by adjuvant radiation. Many times what I did was I also did only brachytherapy for such patients and then referred them for chemotherapy so that these patients receive at least 4 to 6 cycles of chemo. So such combinations can be customized based on, let's say, a particular type of stage 3. For example, in stage 3A, where vagina or the head neck size or serosa or the, stage 3A, where serosa and head neck size involved, or stage 3B, where vagina or parametrium is involved, we tend to give brachytherapy if the gynae oncologist is very, very sure that he has done an adequate surgery. In such patients, we have given a couple of patients only brachytherapy, and patient goes for chemotherapy like GOG 258, 6 cycles. You are not audible.
Yes, the next question is, how is stage 3B treated primarily, and how reliable is pre-op grading assessed by HPE on D and C specimen?
Okay, so 3B is by virtue of vaginal involvement and parametrium involvement. So such patients would go for pre-op chemo, and then after pre-op chemo, then patient would go for surgery. And after surgery, this patient will definitely require radiation as well as adjuvant chemo. So suffice to say that this patient should receive 6 cycles total, 6 cycles of paclitaxel and pelvic radiation, irrespective of what the histopathology would say after completion of new adjuvant chemo. So the the histopathology report should not be taken into consideration if you have given chemo to decide on adjuvant radiation. It should always be given.
The next question is, when should MRI be done? Will doing MRI after curettage accurately predict the depth of invasion?
So it's a very good question again. If you think that this patient has a Lynch syndrome, for example, then we wouldn't do a biopsy before assessing the, whereas already been undergone a biopsy or a polypectomy or a DNC, then if you plan to do an MRI, please remember that MRI will overestimate the depth of invasion if you do it very early. So typically we would wait for 4 to 6 weeks for the inflammation to settle down. And more importantly, second most important is collaborate with the radiologist. Tell them that we are expecting that there will be an overestimation. So please ensure that you take adequate sequences of MRI to identify the depth of invasion. For example, T1, T2 with contrast and fat suppressed sequences. So all these sequences would assist the radiologist to identify the depth of invasion adequately after surgery, after polypectomy or DNC.
The next question is on dose of EBRT and brachy in post-op setting and in inoperable setting.
So in post-op setting, if you are giving brachy alone, as I showed in my slide, we typically treat 3 to 4 centimeters top of vagina, and the prescription is 7 gray into 3 fractions. 7 gray is prescribed at 0.5 centimeters from the surface. And having said that, these days you can also do a CT or MRI with the applicator in place and make sure the vaginal wall is radiated to adequate doses of 7 grain to 3 fractions, either given once or twice weekly in 1 or 2 weeks time. For a combination of external and brachy, external usually 45 gray is given to the pelvis, and brachy boost 6 grain to 2 fractions at 5 millimeters from the surface. For definitive radiotherapy, again brachytherapy, if brachytherapy alone, 7 grain to 4 times is what we practice. If you think that the tumor is larger, you could give 7 into 5 brachy alone. If you are giving external plus brachy combination, then it is like cervix, 45 gray external beam, and then brachytherapy boost 7 into 2 or 3.
Thank you, sir. Dr. Sujata and Dr. Asthas, thank you for your excellent talk. Dr. Sujata mentioned that the importance of oncopathology is very well depicted. The next question is regarding brachy boost dose in PORTEC 3, that's 5 gray into fraction, and ESGO guideline suggests any dose between 8 to 11 gray into fraction. Yeah. Which should be preferred?
That's again a good question. So, lot of different regimens have been used for vaginal brachytherapy. ABS is recommending something. European, American big institutions are doing something else. In Europe, the PORTEC group is doing for 5 to 7 gray. There are other countries in Europe who would do 7 into 3. Then Southeast Asia, people again are doing more number of fractions with less dose. So the consensus was that the evidence is for somewhere between 5 to 8 gray. So 5 to 8 gray given in 3 to 5 fractions is what has shown the optimum schedule to minimize the vaginal recurrences, at the same time not give toxicity, vaginal toxicity too much to these patients. So that is why they stick to this schedule to incorporate various institutional practices which have reported long-term outcomes.
Thank you, sir. The next question is role of neoadjuvant therapy.
So I think I mentioned that in advanced disease and metastatic disease. In advanced disease, neoadjuvant chemo is given, and once response evaluation is done after 3 to 4 cycles, then assess for surgery, and then surgery is done, and then you give adjuvant pelvic radiation and chemo if required.
Last question, perhaps for this session. Can you please mention synchronous low-grade endometrial ovarian cancer? How to diagnose it, because it's not stage 3A and it's a synchronous 1A low-grade.
So many times in the situation, you will always find low-grade endometrioid adeno-CA of the uterus as well as low-grade endometrioid CA of the ovary. This is a classical combination you see in your routine clinical practice. Let's say in stage 1, grade 1, low-grade endometrioid adeno-CA is low risk, so you're not going to give any adjuvant radiation, right? For stage 1, endometrioid adeno-CA of the ovary, which is typically unilateral, it is usually unilateral. In such situations, we also tend to not give any adjuvant therapy, even if there is a capsular breach, because there is no big evidence for endometrioid adeno-CA of the ovary that chemotherapy helps. Whereas if it is stage 2, stage 3, whether it is endometrium or ovary, then this is a classical approach where we would give adjuvant chemo first and then give adjuvant radiation, or at times we give only brachytherapy and send the patient for chemo 6 cycles.
Thank you, sir. I think, sir, questions are still pouring in. One question is, any specific guideline for young female with endometrial cancer, especially fertility preservation, related to fertility preservation?
These are patients who would have a Lynch syndrome, where you could identify the early endometrial cancer. There are a couple of reports where they would try and do a hormonal manipulation as a treatment for patients. And based on let's say patient desire for fertility, patient desire for children, pregnancy, they would defer the definitive treatment for patients who have early endometrial cancers. And after hormonal manipulation, once the patient conceives and delivery is done, these patients definitely go for definitive treatment for endometrial cancer later on. because this is very important, because after the kid is born, they usually forget that they had endometrioid cancer. So if this has to be offered, it has to be offered in a very careful, cautious manner, so that patient should be informed that there is a risk of dying because of endometrial cancer, and they should be following up regularly for treatment. One thing which I did mention was in histopathology was we tend to also ask pathologists to report on estrogen and progesterone receptors. And the reason why we do it upfront is once surgery is done, this estrogen progesterone receptor status becomes very important in further follow-up. So say, for example, if patient gets a recurrence after 8 or 10 years, if they are ERPR positive upfront, there is a scope for giving hormonal therapy as one of the treatment modality for these patients. And mind you, these patients are very elderly, these patients have comorbidities, these patients are invariably not suitable for any systemic therapy. In such situations, hormonal therapy in the form of letrozole suffices as a treatment modality for them when they have recurrences.
So one question related to radiation and bone marrow suppression. Even with using the sophisticated techniques, there are instances when there is significant bone marrow suppression. So how to deal with that situation? And what should be the usual timeline by which the radiation for endometrial cancer should be completed?
So there is no hard and fast overall treatment time in endometrial cancers, but extrapolating it from head and neck and cervix, we always say post-op adjuvant therapy, radiation therapy should be started within 6 to 12 weeks, and preferably completed as early as 16 weeks. But having said that, now with the combination of chemo and radiation, this needs to be investigated further. But having said that, as I said earlier, we try to push in brachytherapy first so that the local recurrence is reduced as much as possible if patient qualifies for more aggressive systemic therapy. Whereas if patient who is a candidate for both combination of external and chemo, then we try to push in 4 cycles of paclicarbo, and after that we give pelvic radiation, because if you see the GOG-258 and earlier GOG studies, the compliance to 6 cycles of chemo is not very good. But for 4 cycles, they definitely have a good compliance. And patients who do not have neutropenias, severe neutropenias, these are the patients who would benefit. And for patients who really do well are the patients who do not have any treatment breaks in form of adjuvant chemo and radiation.
So what should be the alpha by beta to be considered for endometrial carcinoma? The 10 or 4.5?
Yeah, it is not sure, but it is definitely not 10. It should be considered lesser than 10 as compared to other tumors. And I would err on making it anywhere between 4 to 6. That would be more appropriate because of the adenocarcinoma and endometrioid histology. But for type 2 histology, I'm not sure, but type 2 histology may be 10 or more than 10.
The last question for today from Dr. Subrata Saha: what are the deciding factors regarding length of vagina to be treated? Any role of grade regarding this?
Any role of?
Grading in deciding length of vagina to be treated?
No, the length of vagina for endometrioid, as I said, irrespective of stage, we treat only upper 3 to 4 centimeters. Then there have been reports in clear cell and serous where they tend to treat upper half of the vagina, but of course, the evidence is very weak for serous and clear cell histology. Grade has no much meaning on the deciding the length of vagina, because grade and depth of invasion decides on lymph node dissection and the prognosis of the patient and adjuvant treatment. It would not decide on what length of vagina we need to treat.
Thank you so much, sir.
Okay.
And it is a great listening to you.
Thank you. Thank you, everybody.
I think so. I think so. I did not request you for MR brachytherapy, and this lecture says it all, that on a topic where there is so much of controversies, it merits listening to you.
Thank you.
Thank you for this wonderful lecture.
Thank you very much.
And we'll also be interested to listen from you about MR brachytherapy in future.
Sure. Definitely. Thank you.
Thank you so much, sir.
Thank you.
Have a great day.
Appreciate your efforts. Thank you.
Thank you so much, sir. Good day and good day to everyone.